on horrible EKG, horrible ventriculogram, and 2 weeks later, or 3 weeks later, his echo is normal ejection fraction, 60–70%, EKG normalized completely.
Can this cause them to arrest?
Yeah, you can die from it.
Do they also call it the broken heart syndrome?
Yeah.
Yes, exactly.
So there was
That's
just,
exactly
what,
it.
was that your case that was like all over on the news?
Oh, I haven't
There
heard
was
of
one
that.
just like last week,
Oh, really?
yeah, on
I don't know.
PGW.
I hadn't heard.
It
Woman
could
suffers
be.
broken heart syndrome.
Oh.
But
okay.
it's a
Google
real
that.
phenomenon.
There was actually a woman who did the Hood to Coast last year.
I was
Did you
gonna
hear
say,
about that one?
we had one last
Yeah,
year.
that went to Seaside, and basically she had some dental problems, so she didn't train for the Hood to Coast at the last couple of weeks. So she was running the whole way. She was the run. And when she got into the coastal range, she started developing chest pain, and they, sent her to Seaside and life flighted her to us, and she had
She
normal
was
coronaries.
afraid of failing on the Hood to Coast. She didn't
She
want
just,
to let her partner
I think,
down.
it's not just emotional
Right.
stress, it's physical stress too, because I've had diabetic ketoacidosis patient, come in and have Takasova over on the east side, so.
Yeah, I had another one. They're all stories. Every one of them is a story.
Yeah.
I mean, I had one where a mom, her son lived next door and called over, and she walked over and found him dead, and she had. You wonder why. That's why spouses sometimes die within a year after their spouses die. All right, we're getting near the end here. Untreated diabetes, hypertension, dyslipidemia, anterior burning, chest pain, and arm tingling. So here, this looks pretty straightforward to me. I mean, this looks like inferior anterolateral ST elevation. There's first degree AV block here as well. There's some bit of reciprocal change here. So I would bet this is going to be.
What does V4R look like on that patient?
This one here.
Yeah, what would V4R look like?
What?
If you do it right, when we.
Oh,
when
I'm sorry, if you're looking for
If you look for,
yeah,
and so
ST
if you get
should be
2, 3,
ST elevation.
AVF,
Yeah.
You've got elevation in V4 and V5, so what would V4R would
Right.
also be elevated?
I couldn't guess for sure, because sometimes when you see anterior and inferior, it's because of an LAD that wraps around the apex and catches part of the inferior wall, but it may not touch the right
So
ventricle.
it's not extending.
So if it's a big right coronary artery and it hits the right ventricle, then you'd see a VR4. So it's really hard to predict. So in this case, it was a right coronary, so you might have expected RV damage, although I don't see any big marginal branches coming off here, but this is a pretty good sized right coronary artery. There could be one closed right here. So that could have been a right ventricular infarct. It's a very diseased looking vessel. This lady woke up with chest pain. It looks like inferior here. So she has LVH. Voltage greater than 11 millimeters is LVH here, and then ST depression. Also see that right bundle branch block of RSR prime. So this is a little bit of a confusing EKG, but this would put it in the realm of a STEMI from your standpoint. So inferior ST elevation with right bundle branch block and left ventricular hypertrophy. So you're getting 3 curveballs here. You're getting LVH, altered repole, but with the right bundle, that's a little different, and then you have inferior ST elevation. So you see it was totally shut right coronary artery. Whoops. Let me see. I don't want to give you too many of these and just wear you out, but 68-year-old smoker with anemia, 1 hour of chest pain. If you feel the EKG, pretty hard to see, but there's ST elevation up here. Let me see what the next one looks like. Yeah, the kind of lateral leads. And this was actually, an LAD, left anterior descending artery occlusion, and opened up with angioplasty here. So usually it would have come down this way, now you see it here. So caught part of the lateral, this big diagonal branch probably caused the so you can see that the anatomy tends to correlate with the EKGs, but you'll have some curveballs. This is a patient I threw in here with acute pericarditis to clarify that a little bit. Here you see the diffuse ST elevation all the way across, inferiorly, high level, no reciprocal changes, PR segment depression, no QT lift prolongation. So that's kind of the steps I go through when I try to put that together. And let's see, what was this one? This one was a weird one. That was normal coronary. Okay, somebody had dynamic EKG changes. yet normal coronary, so you can get fooled by people. And it's just an example that we, all of us can get fooled. I think that's all I have for this one, and then I have your individual cases, but maybe I'll just take a break, a glass of water or something, and I'll show you a few more, answer more questions. Assess the patient's age, symptoms, look at their major medical issues when you see them. We talked about the diagnosis of STEMI and the other false positive situations, and our false positive rate up to 20%. Lately, it has been 20% for us, even with all this talking. If you ever come to visit us, you're welcome to stay around and watch a case if you don't have to get right back. I know you're under time pressure, but we welcome you all in the lab, and you can ask questions. Everybody there is a good teacher, and happy to have you. Maybe Marla, you can take questions while I'll just show your cases here.
So, I collected the cases that came from Ocean Beach via EMS, because we've had quite a few. It's kind of astounding, makes me worried about being here. It's astounding how many Ocean Beach transports we've had with acute MI. And quite a few of them came in via EMS, and Dave and I started working together, I don't know, it's been a year probably. Yeah, and I kind of emphasized him, hey, we're receptive, and we'd like to set up a program where EMS activates Ocean Beach, and Ocean Beach pulls the trigger and calls Lifelight, so we can take a little bit of this transport time stuff off. It's been really successful. I feel like, we've done a good job, and in the last, probably 6, 7 cases, or maybe 5 cases that came from EMS, Ocean Beach had alerted Lifelight before the patient even got there. So, that really makes a big difference in this world of having challenges with transportation, because you might call Lifelight, and they might not know they can't fly until like 15 or 20 minutes, and you've at least saved that time. And when your crew comes in and you say, hey, we just found out Lifelight couldn't fly, can you dispatch that a crew needs to come to take this patient to St. Vincent, then all that time is saved, just by talking about it before they get there. The diagnoses have been right on. I think we've had maybe 1 or 2 cancellations in all those cases at the most. And yeah, it's gone really well. And then, of course, there was that beautifully perfect case where Lifelight just happened to be at the hospital and didn't have anything better to do but wait for our STEMI that was coming in by EMS. When Dave and I talked, we thought, there's never going to be a time when we don't have to give lytics, because we can't really anticipate being able to get them there within 90 minutes. But that particular guy...
Well, I'm sorry to say,
I think you saw
Marla,
that.
that my images aren't showing up on the disc from your presentation here. So I have the angio images,
Oh,
but
that's
I don't have
sad.
the EKG, which is very
Can you
sad.
can you do your laptop thing? Do we have time to switch over?
Yeah, we can take a break, and I can pull it up on the laptop.
Let's
I'll
try
that.
it, just because that's more pertinent to them. Not just a slave drive. Yeah, which he always